I have two questions to Dr. Andersen.
1 second.
Yes.
Thank you. Go ahead.
The first one is, if you have a patient in sinus rhythm with no history of atrial fibrillation, he comes with a stroke, ischemic stroke, and you do a TEE and find a left atrial appendage thrombus. Should you assume that the patient has paroxysmal silent fibrillation, or do thrombus in the appendage happen also in patients who don't have AFib? And question number 2, if you have a patient with atrial fibrillation who is on anticoagulation and comes with an ischemic stroke, do you suspend the warfarin for 2 weeks before reinstating it, or do you continue it just for the risk of hemorrhage during the ischemic period?
Two difficult questions. The first one, I don't know what to say about it, but we will do our best to detect paroxysmal atrial fibrillation in such a patient, and probably we will implant a device to find the cause of this thrombus. I don't know if I'm the right person to answer that question. Maybe you yourself can answer it better because you are the cardiologist.
Well, yes, but I'm asking this because it has some implications. In my center, the patients with stroke that do a TEE are the patients with cryptogenic stroke, not everyone. And I wonder, because atrial fibrillation, hypertension, old age, peripheral arterial disease increases the risk of atrial fibrillation. Maybe we should do a TEE in every patient just to look at the left atrial appendage. But then I should know, I should need to know.
But in most patients with AFib, you will not find a thrombus in the
No,
appendage.
but if you have a patient who doesn't have a history, you don't know that the patient has atrial fibrillation.
That might indicate that there is a
that's why I'm wondering.
Yes.
Or
so we will do our best to document that this is the case.
Okay. Thank you.
And there's a second question.
Yes, if you have a patient with atrial fibrillation who is on warfarin and comes in with an ischemic stroke, do you suspend warfarin for 2 weeks, or do you continue warfarin? And I'm asking because
I think we will continue warfarin, or we will find out what is the problem, because he can have a concomitant disease like carotid stenosis that could be the problem in such a case. In many cases, it's overlooked that patients also have general atherosclerotic diseases, and warfarin is of no use for carotid stenosis.
But I was thinking of the risk of hemorrhage because
yes,
that's
but in that case, the patient had an ischemic
stroke,
problem. Yes.
So the risk should be low.
So yes, probably.
Okay.
But
Thanks.
we will probably also find another cause for his stroke.
But you wouldn't discontinue the warfarin during the
No,
acute
not if
period.
there's an AFib in this case, and it's well-treated patient. Yeah.
Okay. More questions?
Yes, on this side, John. I have actually 3 questions. One is to John, and is in line with the previous speaker. If you look at CHADS or CHADS VASC scores, even in the general population, how well does that how high is the stroke risk in these patients? Does CHADS score per se or not already make for a high stroke rate, regardless of whether you show that people have atrial fibrillation, yes or no?
Yes. Obviously, the ischemic stroke rate is higher than patients without those factors, even if no AF has been documented. But it's nothing like as high as if AF has been documented. Secondly, of course, there's an incidence of hemorrhagic stroke, particularly with some of the cardiovascular risk factors such as hypertension and so on. So, of course, they do indicate a higher risk of stroke in patients with normal sinus rhythm, as well as in patients with atrial fibrillation.
And I had a question for Dr. Andersen. You were talking about starting anticoagulation after ischemic stroke. So if patient there's a risk of bleeding after an ischemic stroke. So when do you is that also in the chronic situation, or is that only in the acute situation? Because otherwise, the let's say the problem with the oral anticoagulation to start that is only in the first couple of weeks, but that will dissipate after a couple of weeks. Or is that still the case in the chronic situation, that there is still a higher risk of bleeding when you start vitamin K antagonists in patients with an ischemic stroke? Or does that completely disappear, that higher risk?
No, it's a yes for both questions or both situations, but
Okay.
the bleeding is far more higher in the acute situation, the first 2 weeks.
But
We
there
have
remains
this problem with hemorrhagic transformation. In 40% of all patients with ischemic stroke and atrial fibrillation, they will have a transformation within the first 2 weeks. And probably it's a risky business to put them on anticoagulation in that time period. But also after, in the chronic phase, they have about doubled the risk of bleed
So
compared to all others.
So that means that at least the contraindication to a vitamin K antagonist remains even in the chronic situation
Yes,
then?
also.
Okay. And another question was on the hemorrhagic stroke.
No, did he say contraindication? No.
No.
Well,
No,
not a
of course
but at least a relative contraindication. There remains a higher risk if you put these patients on
Yes, you
oral
always
anticoagulation.
have to look at it. And if they, for example, have uncontrolled hypertension, you put the patient in a very high risk of a bleed.
Okay, okay. And is that the same then for patients that have already shown a bleeding, that have a hemorrhagic stroke? Is it indeed wise to put them on anticoagulation drugs again?
There is pro and contras, and you always have to look in the individual patient. But if the patient have had a bleed and on a well-controlled hypertension or blood pressure, then he is extremely high risk of a new bleed.
Okay.
And that's on everything you can think of, aspirin, clopidogrel, all the things.
So that's the hypertension that actually does then
Hypertension is one of the problems, and then the amyloid angiopathy is also a problem.
Okay.
And it's invisible in many patients unless you have done the MRI scan.
Okay. Okay. And then my last question, thank you, to Dr. Tondo. If I look at your recommendations, combining an EP procedure with left atrial appendage closure, it seems to be a bailout option for you, only if the vitamin K antagonists are not working or are absolutely contraindications. Is that a true statement?
Yes, it's a true statement. For the time being, I'm very cautious right now just to extend the indication for other categories of patients. Even though I do really think that probably if we had the the chance to properly select patients, probably I would do much more. And just by going back to the discussion that we had just before, I do a ref on the basis that you have stated this morning, even though I still quite I have some perplexity concerning the myocardial changes in the reach between the left atrial appendage. I don't know what kind of injury I could promote in that area, and probably Dr. Cook knows much better than ourselves. So it's still an area where I'm really cautious right now.
More questions?
Yes, quick, please here.
Sorry.
A quick question. I'm coming back on the issue for Dr. Andersen, an embolic stroke, ischemic stroke after atrial fibrillation, an acute phase. Won't you switch to heparin, at least for a while? Make sure you don't have a major bleeding. You can convert instead of keeping the Coumadin.
Yeah, sometimes we use heparin in a lower dose in the gap between the
2 weeks?
About. But also using heparin is the same as VKA. They have the same bleeding risk, so the only thing you can do is choose it in a lower dose.
Okay. And one subpopulation, actually I want to comment from the panel. Elderly patients with significant coronary artery disease, at least to our view, interventional cardiologists, we concern the issue of drug-eluting stents or no drug-eluting stents if they have atrial fibrillation. So that could be a population in the future where, if you have the proven ability to put a closure device and avoid this, maybe the combination aspirin, Plavix, your comments on that.
Myself, I fully agree with that. I think this is an under-study population. We should absolutely trials in this kind of population because it's a growing population and the patients are older. They have coronary heart disease and AFib often. So I think it's going to be a growing population in the future, and we should probably consider strongly to study these patients. I agree fully with you. And I think a potential trial in that population will be because we have often no choice after drug-eluting stents to give the dual antiplatelet therapy, and to add that on anticoagulation for a year, it takes a long period to expose this patient to high bleeding risk.
The European view is not to continue triple therapy for as long as a year in such a circumstance. But that being said, obviously there is some advantage of using the left atrial appendage occlusion approach to the management because you can cut the anti-thrombotic therapy by one important component, potentially. Of course, we also have biodegradable stents coming up that might solve our problem as well. So I think we have to watch this space for the time being, but certainly that is the option you raised is an important one.
Here we go. If you have a patient who has a massive life-threatening GI bleed, gastric bleed due to a peptic ulcer or something which is curable and treatable, is that regarded an indication for the plug? Knowing that they can get recurrence of GI bleeds, or would one, treat the ulcer and then be happy to put these patients back on warfarin? I just want to know what the panel would think about that. Or
patients with peptic ulcer, active peptic ulcer, that in patients bleeding from peptic ulcer, there is no specific information about what to do with oral anticoagulation. We have a small, very low information about what to do with antiaggressants, aspirin or clopidogrel or so on. In these patients, antiaggressants may be introduced after 3-5 days after achieving the hemostasis, and there is no risk for further bleeding. And in patients taking anticoagulants, we don't have information, but probably we can, and in our experience, we do the same with aspirin or clopidogrel. We reintroduce the warfarin or acenocumarol after 3-5 days after achieving hemostasis and before leaving the hospital.
yeah, I'm thinking more in the chronic, in the long term. The patients I found are very reluctant to go back on warfarin once they've had life-threatening bleeding, blood coming out all orifices. So there's obviously a risk of recurrence of the peptic ulcer. Is this regarded as a valid indication for the plug, for the left atrial appendage plug, or not?
Well, I think peptic ulceration, I think there is something in the chronic thing, the history of peptic ulceration, once it's controlled, I think they can go back on anticoagulants.
We don't have chronic peptic ulcer, we don't have.
No, with the history of peptic ulcer, it shouldn't stop you going, once it's been treated, shouldn't stop you going back on anticoagulant.
The problem in long term in this patient is not in peptic ulcer or in lesions that we can identify and effectively treat. The problem is patients with no etiology to explain the gastrointestinal bleeding, or in those patients bleeding from angiodysplasia despite repeated endoscopic therapy. This is the problem in gastrointestinal bleeding.
Robert?
My question relates to the Danish data registry presented by Professor Andersen. I believe that the scientific community considers the Danish registries in general, especially in the arrhythmia field, as probably as the most reliable, probably in the world, because they have a very high quality of control. My question, I was a little bit surprised by the relatively low incidence of atrial fibrillation in the registry. If I remember well, when only 5% of patients who are younger than 65 have atrial fibrillation, yes. About 15% of those who are 65 to 75 have atrial fibrillation, and above 20% of the octogenarians and older. So my question is, on what data is this, are these numbers based? Is this the occurrence of atrial fibrillation at the moment of admission to the hospital because of stroke, or is there a little bit more explorative work in the history of the patient performed?
Not all of the AFib patients are in the registry because they will be discovered as paroxysmal atrial fibrillation later on. But it's maybe 5% missing on that base.
Rosenqvist, Stockholm. I have another question to Dr. Andersen. If you find a patient with silent atrial fibrillation, how long do you think that episode should be before you consider this patient a candidate for oral anticoagulation? And secondly, how often do you think you have patients with silent AF in your stroke population?
What do you mean by silent AF? What is that?
What I mean, if you have a patient with an ischemic stroke,
yes,
with no previous history of atrial fibrillation, you said before that you really try to exclude that that patient has atrial fibrillation. So my question is, if you find silent atrial fibrillation for 10 seconds or 20 seconds or 30 seconds, does that make a difference for you when deciding to start anticoagulation or not?
I'm not sure I understand what are you...
Okay.
If we find a patient with AFib for...
Yes, and it's 10 seconds. Is that
10
enough?
seconds.
Is that enough for you to start?
No.
No. How long do you want it to be before starting anticoagulation? That's my question.
So no other cause, he means. No other cause.
It's a
Because
question
you
that
said-
cardiologists find difficult to answer, Dr.
Yeah,
Andersen.
I don't think
So
I'm
we
the right
understand your
person to-
difficulty as well.
But thanks for your... I think, well, 30 seconds?
30 seconds would be more persuasive, Martin.
Are you?
Tell us, hand the microphone back to Martin, and he can tell us how much AF he needs.
What do you
Yes,
think?
we have screened patients with ischemic stroke without a previous history of atrial fibrillation. And in those patients above 75 years, we find about 14% with previously unknown atrial fibrillation. But we screen them only for 10 seconds. And what I would like to know is, is that enough? Because in the ASSERT study, patients who had more than 6 minutes of atrial fibrillation over a 3-month period had a higher incidence of stroke compared to those who did not have stroke. So my question is rather, does the AF burden has an impact on the risk for stroke?
Yes.
So we should know, do we have to treat all patients with short bouts of atrial fibrillation, or do we need them to have long episodes before we start?
It's a discussion
Anticoagulation
that has not ended yet, as far as I know.
We don't know from ASSERT, of course, whether shorter episodes than 6 minutes would also have been predictive of stroke, because they could only measure the 6-minute episodes. That was the lowest duration. No, they were episodes of at least 6-minute durations. They weren't added together.
I have one question to Dr. Feu. How do you handle chronic inflammatory bowel disease like morbus Crohn colitis ulcerosa.
Sorry.
So chronic inflammation.
Yes.
First question. Second question to John. How do you count well-treated arterial hypertension? Well-controlled with 1 or 2 drugs, no additional risk factors. Do you fully count that for the chest?
You mean as risk for anticoagulation, thromboprophylaxis? We do count that, yes, because that was the assumption about the definitions coming from the atrial fibrillation investigators' data that form the basis for the CHADS-2 scheme. But as you know, in all of those trials, controlled hypertension was variably described, and all of those trials took place in the 1990s, early 1990s. So whether it still should count as much as it does in the scheme is less easy to say. But when we looked at it, or when it was looked at in the Danish registry, hypertension as it was defined there, which was a history of hypertension, was predictive of thromboembolism, and therefore, yes, we do. But in Hasbled, it's completely different. It is uncontrolled hypertension at the time of administration of the anticoagulant. It's not the same definition at all.
Inflammatory bowel disease. In patients, chronic inflammatory bowel disease, usually these patients are in a clinical non-active situation. In this case, there is no problem to give oral anticoagulants. When they are in active situation, the inflammatory bowel disease is active, then we try to maintain anticoagulation, but if there is an important problem with the gastrointestinal bleeding, we stop anticoagulation. And the problem is not the anticoagulation, the problem is to apply a specific and effective therapy to control inflammatory bowel disease as soon as possible.
Yes.
May I have, okay, I just took take the liberty. Just one brief question to Professor Andersen. I was quite struck from the MRI pictures that you show us concerning the microbleed. And if I understood well, there's a contraindication to anticoagulation treatment. So could you tell us how do we need to behave? I mean, I was really surprised. I mean, I really afraid if I have patient with, and it is a progressive process, and what we had just to do in this clinical context.
It's not a contraindication, but a relative contraindication. You have to consider it when you weigh pro and contra for treatment. We have not enough knowledge about this problem yet. So it's not an established contraindication, but they have higher bleedings. That's established.
Well, thank you very much to the panel, and thank you very much to all of you.